Next, we're gonna move on to is deep brain stimulation right for me? And that is going to be with Dr. Iahn Cajigas. Dr. Iahn Cajigas's clinical expertise includes PS, focus ultrasound, stereotactic radiosurgery for movement disorders, management of refractory back pain with neuromodulation, and the surgical radiosurgical treatment of trigeminal neuralgia. Research focuses on understanding the real-time control of movement by the cortex and spinal cord using state-of-the-art intraoperative techniques. This understanding can empower the next generation of functional neurorestorative therapies and devices. Dr. Cajigas completed his residency at the University of Miami-Jackson Memorial Hospital and his fellowship at the University of California, San Francisco. He joined Penn Neurosurgery in 2021.
Great. Thank you so much for the introduction to Gabby, and thanks to Dr. Feldman for a great summary of the medical management strategies that are important to sort of first-line therapy for helping patients with essential tremor. I'm going to just share my screen and this up here. Everybody see my screen okay? Make sure the sound is shared. All right. Here are my disclosures. So my goal today is to talk about is deep brain stimulation the right option for you? Like Dr. Halpern said, they're typically, we talk about the 3 Ps, primidone, propranolol, and procedures. This is one of the 3 the procedures that we can do to help patients with essential tremor that remains bothersome and is affecting your activities of daily living despite adequate trials of medication. You know, it may not be the right option for everybody, but it is one of the options that's available. And our job today is to sort of summarize the available options and help you navigate them. So as an analogy, DBS is very much like a pacemaker. And I like to think about how we intervene in the brain with either ablations or with stimulation, just like we do in the heart. So to make that analogy, think about heart and its rhythm, right? The beating of the heart is very important in its function. And you know, when the heart is not beating normally, you get problems in the body with circulation. And so cardiologists have tried to fix the problems with the abnormal rhythms in the heart by either pacing the heart in a very controlled way, so you can restore those rhythms and the heart can work as a pump back as it normally would, or we can create ablations in the heart to fix the conduction of the abnormal electrical activity. And so those are going to be the 2 main options we'll discuss today, either ablations in the brain or stimulation in the brain. And you can think about essential tremor, just like these abnormal rhythms in the heart cause it to dysfunction. These abnormal rhythms in the brain's electrical activity manifest as tremor. And our job with DBS is to disrupt that abnormal circuit to restore the normal rhythms and therefore help with the tremor. We can do the similar things with the ablations by disrupting those abnormal circuits to restore, again, the balance of the normal electrical activity. So what does that actually look like? So deep brain stimulation involves the placement of a lead into the brain, deep into structures such as the basal ganglia, which are very important in the regulation of movement, or in the thalamus. In essential tremor, that area where we put electrodes is typically in an area of the thalamus called the ventral intermediate nucleus, or the VIN. You might see in different web searches if you're looking up these interventions. And it's really just a node in the thalamus that is very important in the synchronization of information between the motor cortex that's sending the signals down to the body and also receiving signals from things like the cerebellum and integrating that information to allow movement to happen smoothly. And so that is the brain target that we use for deep brain stimulation in essential tremor. The system is then connected with leads that go under the skin, down behind the ear, down to the level of just below the clavicle, just like a pacemaker would sit Think about it again as a pacemaker for the brain, restoring the normal electrical balance of rhythms. On the right-hand side of the slide, you'll see that there are many different devices, that give us different options in terms of the management. And our job, when we're considering deep brain stimulation as a therapy, is to go over the pros and cons of the different devices so that we can help find the best device for you. There are rechargeable and non-rechargeable devices, which you see the rechargeables on the top end here, a little bit smaller because they don't need to carry all of the charge in them for the longevity of the device, and the non-rechargeable devices that are here in the bottom, which are a little bit bigger. The non-rechargeable devices can last 15 years before they need to be replaced, whereas the non-rechargeable devices last 3 to 5 years, depending on how much stimulation is being used. The recharging for the rechargeable devices with all of the new versions, usually it takes about 30 to 40 minutes once or twice a week. And we can go over the details of how that happens. Just for context here, this is one of my neurology colleagues' credit cards. Unfortunately, the number is not visible. So just as a reference in terms of the relative size, you can see they're quite small. The battery that you see here on the bottom left is a Medtronic Percept PC, which you can see just from the shape here. You can see it's a little bit bulkier than the corresponding rechargeable. And you can see that the incisions are small, that the new devices are low profile. You can barely see that there's anything under there. You can see just a remnant of the prior incision. So at Penn, Dr. Q, Dr. Halpern, and myself tend to do the DBS surgery in 2 parts. This is the first part is where we place the electrodes into the brain. This requires using a specialized frame that is used to keep your head really still while we do the procedure. It also gives us a special coordinate system for the brain, an XYZ coordinate for every point in your brain that we can then use to precisely get the lead to the brain target. We confirm that the lead is in the right spot using a combination of an MRI that you obtain before surgery and this frame that we use in surgery. We also sometimes record from your brain, and which I'll show you some examples of, to make sure we're recording from the right types of cells. And then lastly, we tend to use an awake testing to make sure that the stimulation not only is helpful for the tremor, but that there are no side effects to the stimulation. The benefit of this is if there are any side effects, we can do repositioning of the electrode with millimeter accuracy to a new spot that will have the same improvement in the tremor and the lack side effects. On the top here, you can see an example of the type of testing we might do in the OR. We don't bring in glass cups here at Penn. This is an older video, but we might do things like intraoperative spirals like this, just so that we can compare once the stimulation is turned on, that the tremor actually gets better and that the spirals improve. The surgery takes about 1.5 to 3 hours, depending on whether one side or both sides are being done. And this is a really important thing when considering the type of tremor that's present, if it's affecting just one side of the body or both, and knowing that with DBS, sometimes we can actually address both sides simultaneously, whereas with things like focused ultrasound, we can only target one side at a time, just because of the risk profiles and the approvals from the FDA. After the surgery is concluded, we take that frame off. We typically leave the leads coiled behind under the skin, sort of just at the top of the head on one side. And you spend the night in the hospital, and let's say about 95% of patients go home the next day. About 1 to 2 weeks later, we do a short outpatient procedure that takes between 30 and 40 minutes to connect the leads from the head down to the battery that sits at the level of the clavicle. We tend to place the battery on the right side so that if you ever need a pacemaker in the future, that typically goes on the left. But there are certain circumstances that we will put it on the opposite side. particularly if folks that like to go hunting and might want to carry a gun on that side. We don't want that kickback to affect the battery, so we can definitely move it. Sometimes also if folks have had surgery on that right shoulder and it's uncomfortable, or had fractures and it's just not the best location for them, we can place it on the left. And actually, sometimes if neither the left and the right is an option, the battery can be placed in the abdomen. We also, across all three of our colleagues on the neurosurgical side, we tend to turn the system on at a low dose, typically when we implant the battery, just to start getting some relief. But the ultimate management is by our colleagues in neurology, like Dr. Feldman, who will then optimize the stimulation as over time. So, as I mentioned earlier, deep brain stimulation, we're using electrical stimulation to disrupt abnormal signals in the brain rather than creating an ablation or a lesion. There are pros and cons to any intervention, and in the clinic, we will discuss these with you in detail. The main pros for deep brain stimulation is that it is reversible. This is something that we can place an electrode there, and if for any reason we need to remove it, say there is an infection or it's just not an effective therapy for your treatment, which is very, very rare, I should say, we can remove the equipment and the brain is not injured. It is adjustable. So if the symptoms change over time, we can make adjustments in the office without another surgery, just by using a special patient programmer to give more stimulation and help with the symptoms. Now, important to understand that this is not curing the essential tremor, or if this were a Parkinson's tremor, the condition may change over time. This is not a cure for that, but it can be a very effective treatment. And if the condition changes over time, this gives us an adjustable way in the clinic with low risk to account for those changes. As I mentioned earlier, we can typically treat both sides of the body at once with deep brain stimulation. The rechargeable batteries can last 15 years before they need to be replaced, and the non-rechargeable batteries last between 3 and 5 years before they need to be replaced. The replacement procedure, just like that second procedure I mentioned, is about 30 to 40 minutes outpatient procedure where we just open that area, remove the battery, put in a new battery, and replace it under the skin. The downside is it does require, putting the electrodes into the brain, which is associated with risks, which are small but not zero, and may be different depending on other risk factors that patients might have. If folks are on anticoagulation or the high risk of falls, that might be something that gives us some pause about the risks associated with placing the leads into the brain. Additionally, there's a need for an implanted device, which carries risks associated with infection, as does any surgery where you're implanting something permanently into the body. And some patients may not want to deal with the follow-up that needs to happen regarding the implanted device. So this is why it's a very personalized discussion that needs to occur between your neurologist and your neurosurgeon to help you identify the best option. So what gets better? Here we're talking about essential tremor. I have to say that it is remarkable the extent at which tremors improve with deep brain stimulation. What other things that I list here, this is primarily for Parkinson's associated tremor or Parkinson's disease, where we can get improvements in slowness, stiffness, the amount of off time, that is the time that medications are not working. We can sometimes decrease medications. In essential tremor, we usually are able to decrease medications significantly, if not completely. And these other things we can talk about on a one-by-one basis if you were interested in a surgical consultation. Things that do not get better or may actually worsen. So, this is not a cure for the disorder, and we are disrupting brain networks in order to make this work, right? So the motor coordination of speech and the motor coordination of balance can be affected by placing an electrode in this area. The benefit of all the new devices is that they give us the ability to steer the stimulation in different directions, so we can usually optimize settings so that we get very good tremor control with very little side effect of speech and balance. But they can be affected just because there's an electrode there in the brain. I would say also that sometimes it's not possible to get perfect tremor control and not get these side effects because the electricity spreads from the area where it's being applied. So, I'll give you an example. As a fellow, I had a patient who was a concert pianist, terrible essential tremor, could no longer play the piano, had deep brain stimulation, incredible response, able to get his hands very steady and get back into playing the piano, but very high levels of stimulation were required where he was not able to speak very well at his normal pace. He had a little bit of slowness of his speech when he had perfect tremor control. So he actually has two settings on his DBS. One that's his piano setting where his hands are super steady and speech is a little bit affected. And as a second setting where there's a little bit of a tremor, but the speech is normal. And so it may require some optimization in your particular case to get you the right balance of tremor control and no side effect. And that's really where sort of having a good team relationship between your neurologist and your neurosurgeon is very important. How long does the stimulation effect last? All of the data that we show shows that the effect can last for many, many years. But however, it does not change the progression of the underlying disease, whether it's Parkinson's disease or essential tremor. So it is possible that some of the loss of efficacy over time is just due to the severity of the symptoms getting worse. What we do know is that in uniformly all circumstances, if you turn the stimulation off, if there is a little bit of breakthrough tremor, the tremor is actually significantly worse off stimulation. There are certain things that folks try to do to decrease any potential sort of effect where the brain can get used to the stimulation. We have some patients that turn off the stimulation at night just to prevent the brain from being exposed to the stimulation 24/7. And that by some is argued that can help increase the duration of time. But we have patients that have had DBS for decades with continued significant benefit from their stimulation. How do we do this? Again, in the OR, we use a special apparatus that's connected to a frame to very precisely target a spot in the head where we're going to enter with the electrode. And then we listen to the brain as we advance that electrode down into our target. In the essential tremor, that target is in the thalamus. This is for a patient with Parkinson's disease where we're putting the electrode down in the substantia nigra. And we can actually listen to the cells as the electrode advances down, and the cells have different characteristics that help us determine where we are. This is an example of a patient with Parkinson's disease in the next video, just showing how we know we're in the thalamus here. You'll hear a cell that's firing at the same frequency as the tremor. And so we use the knowledge of the characteristics of the cells to kind of know where we are, and that helps us fine tune the placement of the electrodes. We do, as I mentioned, also test for the effect of the stimulation on the control of the tremor to guarantee that not only are you going to get benefit from the stimulation and avoid side effects. So this is an example of intra-op testing. When I was a resident, a patient with essential tremor, they're holding up a little bottle of alcohol. They're not going to drink from that, but it's just to represent sort of bringing something up to your mouth to drink from it. And you'll see it shaking when the stimulation is off, and then you'll see it stop when the stimulation is turned on.
Keep it up there. Keep it up there. I'm going to turn on the stimulation right now. And now I'm going to turn it off. And I'm going to turn it back on. And then I'm going to turn it off.
You can see how dramatic of an effect that is. And then what we do is that we can check for side effects. This is another example of how dramatic things can get in the OR with control of tremor when the stimulation is turned on. You can hear everybody in the OR going like, wow. You could even say somebody say, who's your daddy? Because they're so excited. This is an example of a patient of mine a year ago offered to share his story regarding his experience with essential tremor. So I'll let this video play and just read the captions here at the bottom.
Okay, right. It's a challenge. So it's isolating.
That was a very unique circumstance because when I met Jim, he had his daughter's wedding coming up pretty soon, and we wanted to make this happen for him. So this was one circumstance where we did both the lead placement and the battery at the same time. And this is just the initial settings that I put it in the post-op recovery area immediately after surgery. So needless to say, we've gotten actually a little bit better tremor control over time. You can see pre-op from the top left on the left hand and immediately afterwards on the bottom, and same in the right side. On the right, you'll see this is how we target our electrode. This shows where the electrodes are in the thalamus, this pink structure, and an important fiber tract that we target, which is called the dentatorubro-thalamic tract, and its relative location based on our electrode and the nucleus as well as the tract. This is a procedure. This has risks. It is not perfect, but it is generally quite safe. What are the main risks of the procedure? The first is there's a small risk of bleeding in the brain because we're putting an electrode into the brain, and this can be slightly different depending on other medications that you might be on. So there's a small risk of stroke or bleeding in the brain, and then there are risks related to anesthesia. So just problems with the heart, lungs, clots in the legs that can happen with any surgery. Depending on age, the post-op course is generally well tolerated, but older patients, with a little bit of anesthesia, there's a risk of having some post-operative confusion or just being a little bit tired. The risk of seizure is possible, but very low. The main or the largest risk with any implant surgery is the risk of infection, which is about 3%. Side effects of the stimulation I mentioned earlier, there can be changes in speech or balance. Additionally, the motor nucleus in the thalamus is very close to the sensory nucleus in the thalamus. So particularly when we turn the stimulation on or off, you might feel a transient sensation of tingling or numbness in the hand. That usually goes away as the brain gets used to the stimulation. There are some typical restrictions, particularly after surgery, just to make sure the healing goes well, particularly in terms of we're treating your headache or anything afterwards with narcotics, which is not common, but we would recommend no driving during that period. Also, there can be a little bit of swelling around the electrode, particularly within the first 2 weeks. So we definitely tell folks to take it easy during that 2-week mark, to not have any big work responsibilities, things that are gonna get in your way of just taking some time off and letting things swelling go down over time. Because we do open a small opening around the electrode to place it into the brain, we try to avoid heavy lifting or bringing the head down below the level of the heart, because this increases the pressure around that area and may affect healing. What are your typical post-operative expectations. There's something we call a honeymoon period or lesion effect. Sometimes just placing the electrode into the brain itself can lead to benefit or improvement in tremor, even if the device is not turned on. This can last anywhere between 1 and 2 weeks, and the symptoms will get better initially, but over time they will return as the swelling around the electrode goes down. This is normal. It does not happen to everybody, but does happen to some patients. And again, the symptoms will start getting well controlled once the programming is done. The initial programming can typically happen about 4 weeks after the lead is placed with your neurologist. If it's a Parkinson's tremor, we tend to see patients off their medications to review which contacts are better. For essential tremor and Parkinson's at Penn, we tend to turn the device on at a low dose initially to start providing some relief, with the understanding that the ultimate programming decisions are going to be made by our neurology colleagues. During the first 3 to 6 months, there are several visits to optimize settings to find the best ones that minimize any side effects, as well as if there are any medications that need to be weaned, that they're weaned carefully as the stimulation gets increased. This can take anywhere between 3 to 6 months, particularly for essential tremor. For Parkinson's and other tremor conditions, may be longer, 6 to 9 months. So everything gets adjusted according to how you're doing over time. And you also get some control of the settings yourself. So Dr. Feldman might set program 1 and give you a limit from stimulation of 0 to 1 milliamp. And at home, you go up a few clicks, 1 click every few days to slowly titrate the stimulation to comfortable levels. And there are some long-term restrictions or things just to be aware of when having these types of permanent implants. This is changing based on recommendations from the infectious disease doctors, but you used to recommend initially after surgery to have some antibiotics when having dental procedures. Evidence for this is kind of changing, and so it may not be something that needs to happen, but you should just review these with your particular surgeon after your surgery if you have any immediate procedures in the first few months. Recharging, if it's a rechargeable battery, is very important. We just recommend that it's something that you get into the habit of doing at least once a week. There are certain medical procedures that may require you to turn off your stimulator, like getting an EKG or having another surgery. You should bring your DBS programmer and or recharging devices to your appointments, or if you have a hospitalization for any other reason. And our reps from the different companies are phenomenal, and they will you could let them know, I need to be in this hospital for this procedure, and they're great at connecting you to the right folks. If you do need an MRI for any reason, usually have to touch base with us to have a form filled out to get an MRI. And then when going through the airport, you would go through pat downs instead of the standard metal detectors, because the electrical interference that can be generated by the machines can affect the device. Just like watches aren't rated to go below certain depths, FDA never really did the study to check for DBS in skydiving or scuba diving. So these are off-label uses, although I have patients that have done the scuba diving off-label with no issue, but it's not technically within the scope of when the device was developed for. Direct contact to the device is definitely not encouraged. And things that need to happen, but you should be aware of, if you need to have a defibrillation, that might clear the battery settings or damage the battery, but we can always replace the battery if that needs to occur. And importantly, with DBS, if you're thinking about other trials, particularly in Parkinson's, there are studies on stem cells and the like. Doing some of these current standard of care procedures may affect your ability to participate in clinical trials, because they try to recruit patients that have not had prior interventions. But the benefit of the stimulation is so dramatic that it is one of the best things that we have right now to help with these symptoms. Lastly, it's really a team, and that works with you if you do get DBS. a combination of your neurologist that will help with stimulator programming, managing medications, and doing the titration, neurosurgery, which will work with implanting the leads in the battery, answer questions about the wounds, and any battery replacements, and lastly, the device manufacturer, which can help you with recharging or any programmer issues, and we all work together very often. So with that, I'll end. These are the locations where I currently see patients. All of our surgeries are done at Pennsylvania Hospital, and I'd be happy to take any questions. Sorry for going a little bit over.
Okay, looks like there's a couple minutes left if anyone has a question. A couple patients did mention where if there was some sort of age restriction, whether DBS can be done on like a 38-year-old versus a 78-year-old.
Yeah, so age restrictions, none that are sort of, it's depending on your overall health. When this can be done, it's up to you, the neurosurgeon, and you. I'll tell you, the youngest patient with essential tremor I've done is in their early 40s. 30s would not be a problem. The oldest patient I've done DBS on for tremor was in their 80s, 85. So, age is just a number, as they say. It really depends on your other medical conditions and the pros and cons of doing something like this versus something like focused ultrasound. And it's a very nuanced, personalized discussion between you, your neurosurgeon, and your neurologist as to what your best option is.
Is there any risk for dementia?
So she tends to be independent of what we're doing. Certainly, there can be cognitive changes associated with things like Parkinson's disease that this would not alter. But certainly, there's no risk of sort of precipitating a dementia or severe changes in cognition with this device. If there is any concern cognitively prior to doing the DBS, that is, we typically do a screening in the office to get a baseline of where folks are cognitively. If we have any concern, we typically do a full neuropsychological assessment to make sure we identify what the cause of any cognitive change is, to try to optimize folks prior to surgery to make the process as smooth as possible.
Okay, great. Thank you, Dr. Cajigas.